Thank you very much. Yes, so my name is Mike Bleszynski, and I'm one of the liver transplant, pancreas transplant, and liver pancreas oncology surgeons. And I work with Dr. Kim and a few other of us at Vancouver General. So, in order to understand the latest treatments in liver cancer, um, we have to talk about kind of the basics of how we treat liver cancer historically. And unfortunately, I don't have any disclosures. I wish I had as many as Dr. Yoshida, but maybe sometime in the future. So what are the different types of liver cancers? Well, there's primary liver cancers and there's secondary liver cancers. Primary liver cancers are cancers that originate within the liver itself, and secondary liver cancers are essentially metastatic cancer that originates from somewhere else and goes to the liver. For today's talk, we're going to be principally talking about HCC, which stands for hepatocellular carcinoma. And what hepatocellular carcinoma really is a cancer that originates from the liver tissue itself. Within the liver, there's a drainage system essentially called the bile ducts. And then the second most common primary liver cancer is cholangiocarcinoma, which is essentially a cancer of the bile duct itself. There's also, so in the most common secondary liver cancers or metastatic cancers to the liver are colorectal cancer, or what we call neuroendocrine tumors, melanoma, and breast cancers can all go to the liver. So for today, I want to focus mostly on hepatocellular carcinoma. And to talk about the latest treatments and advancements in this disease, we have to kind of look at the overall management of HCC, what we call local regional therapies, why and when we do liver transplant, and also talk about some of the local and national new things that are happening in HCC treatment. And then really one of the cornerstones in the latest treatments of HCC is new developments of chemotherapy or immunotherapy, which has become a very hot topic in recent years. The one point I want to make about colorectal liver metastasis today, and this is the only thing I'll talk about colorectal liver metastasis, is that in Toronto, a surgeon named by Dr. Gonzalo Sapososhin initiated the first protocol for liver transplantation for colorectal liver metastasis in Canada. And in North America, there's only a few centers that are doing liver transplantation for colorectal liver metastasis. And a few of us with multiple different groups, some of the main surgeons at St. Paul's for colorectal surgery, our medical oncologists, our hepatologists, and liver transplant surgeons, we are working on a protocol in order to create a study to be able to do liver transplantation for patients who have colorectal liver metastasis. It's a very select few group of people, but it's something that we're very excited, that we're hopeful to be able to accomplish and initiate in the coming months. So what is HCC? It's the sixth most common cancer in the world, and it's actually the third leading cause of death worldwide. On average, there's almost 1 million deaths for liver cancer. And when I say liver cancer, I'm going to be referring to HCC. Okay, so it accounts for 75 to 85% of all the different types of liver cancers. And overall, when you take anyone who has HCC, the 5-year survival is about 35%. Now, most of the time we're trying to do surgery, as in removing that part of the tumor from the liver. The recurrence rate, as in when that part of the cancer is removed from the liver and then we follow a patient down the road, there's about a 70% chance that that cancer actually comes back. Now, one of the things that makes HCC tricky is that it's a vascular tumor. What do I mean by that is that it receives blood supply from different arteries and veins from the liver, which make it grow and kind of make it difficult to treat. The liver is a very immune-rich environment, and actually it's a good segue in the sense that, as Dr. Yoshida and others had mentioned today, that the liver is a filtration system. It detoxifies the liver, and it gets all the blood from our bowels and filters everything. And so this makes it an immunogenic area, which can be sometimes difficult to treat. And actually, this is why I think it's funny when you go on YouTube or on Google and you read about liver detoxification. It's a bit of an irony because the liver's sole job, or one of its main jobs, is to detoxify. So you can't really cleanse your liver because your liver's already, like, its natural position is to cleanse things. So it's a bit of a side comment. But one of the things that's changed dramatically in the recent future is that treatment options have advanced much more than historically. So the most common causes of HCC are viral hepatitis, so hepatitis B and C, NASH, as we've talked about, alcohol, autoimmune congenital liver diseases, and it's true obesity, diabetes, smoking. These are all risk factors for the development of cancer. So what does cancer look like? Well, HCC can be very small, it can be very large, it can have multiple nodules within the liver. In worst case scenarios, HCC can spread to other parts of the body, or it can even invade the veins of the liver. So picture here, the Google image here, that's a picture of what we call multifocal HCC, where there's a primary tumor and there's these satellite lesions. And that's a very difficult tumor to treat that's going to be of a transplant kind of situation. Now, the picture on the right is an example of a smaller cancer in someone who had a really good liver function and was appropriate for resection. So this is the type of scenario where if we can try and resect or remove a part of a liver that has HCC, that's usually a primary option that we're trying to do. So HCC arises from a cirrhotic liver. Now, a normal liver is very soft and supple, as we talked about. A cirrhotic liver is very stiff. And a stiff liver is a risk factor for developing HCC. And you may ask, why? Well, it's because a normal liver, soft and supple, there's no active inflammation in that liver. Over time, when you have cirrhosis for whatever cause that we've talked about already, there's chronic inflammation. And it's that chronic inflammation over time that changes the DNA, changes the molecular environment within the liver. And as the liver is trying to heal itself, it creates like regenerative nodules. And that's how HCC can arise, because there's this regeneration and rapid firing of cells that divide, and they're dividing haphazardly, and that's why you get cancer out of that. So liver transplantation as a treatment, as a cure for HCC, is one of the best, that has the highest chance of cure out of all the different options that we have. However, doing liver transplantation is typically reserved for people who have what we call unresectable HCC. So that's kind of based on the multitude or the size and the number of lesions within the liver, and also how sick a patient's liver is. If that someone can't undergo a resection or other types of treatment, we're trying to reserve liver transplant for those types of patients. And the reason is that if we could give everyone a liver transplant, we would. But the issue is that we have to be stewards of liver organ donors, because there's a limited supply of organ donors from deceased donors or also from living donors. And it's a scarce resource. And so we have to protect to really identify who are the best patients who are going to derive the most benefit from a liver transplant for HCC. So the management of HCC is very complex, and it's evolved over the years. And the reality is that the treatment of HCC is not a straightforward algorithm, and it's not done by one person. It's not just done by a surgeon. It's not just done by a medical oncologist. We have heavy multidisciplinary teams that comprise of hepatologists, medical oncologists, surgeons, radiologists, interventional radiologists, and we all meet routinely and regularly to discuss what is the best option for that patient who has HCC. And how we decide that is based on a few different things. One, what is that person's liver function? How bad is their cirrhosis? Can they tolerate an operation? Are they too sick for an operation? How big is their cancer? Is it a cancer that can be potentially cured with transplant, or is a cancer too advanced to be beneficial for transplant? Also, what's the patient's performance status? How healthy are they overall? And so some of these options are, as we talked about, we can cut out a liver, we can ablate HCC, we can do a liver transplant, and we can do some fancy things the radiologists do, which is focal chemotherapy to within the liver, or focal radiation to the liver. And all of these have a different place in the management. So what is ablation? Ablation is when we stick a needle, so this is done by the interventional radiologist, they stick a needle into the tumor and they burn it with high heat. We can also do this surgically as well too. And what about TACE? Well, it's a fancy word that essentially means the interventional radiologist, they stick a needle that goes up into the artery of the liver, and then they're delivering a focused bit of chemotherapy to that tumor. And this is why I was mentioning HCC is a vascular tumor. The goal of this is to decrease the vascular supply to hopefully kill the tumor. And Y90 is a fairly new treatment option for HCC, and it's very similar to TACE, but instead of focal chemotherapy, it's focal radiation. Now, this may be overwhelming, and it's true, it is overwhelming even for us. The management of HCC has evolved a lot over the last 20 years. And so when we're thinking about how do we treat HCC, this is why we do it in a multidisciplinary team. So this is the Barcelona grading and treatment algorithm that's most internationally recognized as kind of the most common way to manage HCC. And we kind of break HCC down into early stage, kind of intermediate stage, and advanced. when someone is the early stage, this is when we're thinking about what we call local regional therapies, when we're trying to ablate the tumor or potentially resect it or maybe even transplant. In someone who's got intermediate liver disease, this is where we're trying to maybe also give some of that direct chemotherapy or direct radiation, and in a situation where someone may not actually derive benefit from transplant. And a lot of advances in the latest treatments of liver cancer have actually come in patients who have advanced stage disease, where there's been an evolution of systemic chemotherapy and immunotherapy, which I'll be talking about later on. So the traditional management of HCC is a bit unilateral or unifocal in the sense that someone would just get an ablation, they would just go get a resection, they just have a transplant, or they're very sick and they just go for chemotherapy. Some of the modern evolution, kind of what we're practicing now, is essentially the above, but we're able to kind of mix and match treatments. So for example, one patient can get focal radiation and systemic chemo at the same time. And then once that patient's when we think that patient's HCC or cancer has been controlled well enough with a combination of therapy, then we can potentially get that patient to transplant. So this has been kind of an evolution where it's been a unidirectional treatment. Now we're using many different treatments at one time in order to provide a potential cure for someone's cancer. Now, the future is very exciting because it's going to take some of the modern things we do, but may switch it up. So currently, we don't really have good evidence for using immunotherapy before transplant, or immunotherapy, or a combination of immunotherapy and focal radiation before undergoing resection. And this is where the evolution of the treatments of liver cancer are going. So one of the kind of interesting examples of the evolution of how we treat HCC is looking at the benefit of Y90, that focal radiation versus focal chemotherapy. Focal chemotherapy to the liver used to be kind of the standard in patients with early cancer, and recently it's been shown that Y90 is far superior in providing stability of HCC disease. And then the next step is that systemic chemotherapy was actually better than focal chemotherapy in not only improving patient survival, but also the stability of disease. And then the next thought, well, if systemic chemotherapy is better than focal chemotherapy, how about combining them both and see how that compares to systemic chemotherapy alone? And so what's been shown is that a combination of systemic chemotherapy and focal chemotherapy directed to the liver is actually better than just systemic chemotherapy. And so all of this kind of highlights the evolution or the paradigm that we can combine treatments in order to improve patient survival and also to improve the stability of disease. And so kind of coming back to liver transplant, what patients or what types of tumors are best derived or are best suited for liver transplant? Well, in 1996, Mazzaferino, he's an Italian surgeon from Milan, they came out with this seminal paper that looked at 48 patients undergoing liver transplant. And this was a very important paper because in the 80s and the early 90s, liver transplant for HCC was a lot of trials were, a lot of studies were being done. People were transplanting all forms of sizes and numbers of cancers within the liver, and the results were not very good. So the reason why this paper was so big is because it showed that patients who had a single cancer that was up to 5 centimeters or 3 cancers up to 3 centimeters each, they had superior survival in comparison to what was being shown before. And these patients were having over 80% survival at 4 years. And so this became a standard essentially in the transplant world, that you shouldn't really transplant people with HCC if they have a cancer that's bigger than an HCC that's bigger than 5 centimeters, or 3 cancers, 3 HCCs that were bigger than 3 centimeters. That was considered a no-go. And it was essentially the standard of care for over 20 years. Now, what's been happening is that there's been an evolution in how we treat HCC from all the different steps that we've talked about. And so a lot of different groups across the world started developing their own extended criteria, essentially trying to push the boundaries of how advanced HCC can be transplanted and see if there's good outcomes. And so a lot of studies have now shown that you can transplant people who have much more aggressive HCC and still have excellent 5-year survival. And so this has been a monumental paradigm shift, and actually it's affected how we practice and how we manage HCC and liver transplant at Vancouver General. So at the end of 2022, we switched from using Milan criteria and only transplanting people with as HCC up to 5 centimeters or 3 HCCs less than 3 centimeters. We switched to now using what we call an extended criteria that's based on a total tumor volume. Okay, and this has been a monumental shift because it allows us to transplant more patients, all right, and still provide excellent outcomes. And one of the other things that is going to be evolving is that we've, under the leadership of Dr. Kim, we're very close to opening up the living donor liver transplant program at Vancouver General. And as a side note, kind of to pat ourselves and everyone who's involved in liver transplant across the province, across every single specialty, we set a record number of transplants last year with 117 deceased donor liver transplants last year. So one of the things that we're doing nationally, this is led by Dr. Gonzalo Saposocian, and this slide is courtesy of Dr. Farah Ladak, is that we're looking across Canada and all the different transplant centers at seeing what type of criteria do they use for transplanting HCC. And we see that there's a lot of disparity across the country. Okay, so one of the interesting things that we're trying to do nationally is look at how does each province or each transplant center transplant HCC and what are the outcomes to see how good are we doing as a country. So now moving on to systemic therapy. So in patients who can't get a transplant or they can't get one of the local regional therapies that we've talked about, they're the candidates who have systemic therapy. Now, prior to 2007, there was no chemotherapy for HCC. There was nothing. If you had advanced disease, that's it. Sorry, you're palliative. So 2007 was very big because it came out, sorafenib was the first systemic chemotherapy that was approved for HCC. And then about 10 years later, not until 2018, there was nothing that came out that beat out sorafenib. And then after 2018, you can see in the last 2-3 years, there's been an exponential rise in studies that are being looked at and to provide more treatments for first-line chemotherapy for HCC. And so now, compared to 2007, there was only one form of chemotherapy. Now we have first-line chemo and immunotherapy options for patients who have HCC and a whole list of second-line therapies of cancer treatment and even third-line, where in 2007, there was only one. So what did that first study show in 2007? Well, it improved survival, but not that much, to be honest. So the median overall survival with sorafenib was 10.7 months, and compared to supportive treatment was 7.9 months. So this chemotherapy only really helped improve survival for almost 3 months for patients who had advanced HCC. So it's still better than nothing, but it wasn't great. So then when lenvatinib came out in 2018, it was the first successful phase 3 trial in 10 years that showed that another drug was non-inferior or as good as sorafenib and in overall survival. But one of the things that lenvatinib did was that it did show improvement for stability of that tumor and delaying the time of that tumor progressing and an objective response rate, as in like how big is the tumor on a CT scan or an MRI. And so the curves here don't look that impressive when we look at overall survival and progression-free survival, but it was a really important study because it was the first study in 10 years since sorafenib that showed there was another drug that could help patients and provide equal outcomes to the original drug. One of the biggest things that's changed was in 2020 when these two drugs came out and were shown to have superior outcomes compared to sorafenib. And this was showing the benefit of immunotherapy in HCC. And so this drug combination was compared against sorafenib, and at 12 months, it showed 67 versus 54% survival in patients who had advanced or unresectable HCC. So this was a really big game changer. Not only did it improve patient survival, it also helped reduce the progression of disease in patients. Another really big trial that is very recent came out in 23, and at least I think it's a very big one because this is the very first trial that showed success for chemo and immunotherapy in patients who've had a resection. They've undergone a removal of part of their liver, and they can get what's called adjuvant chemotherapy. This is a big game changer because up to this point, there was no study that showed a benefit of adjuvant chemotherapy. So sorafenib and lenvatinib and other drugs were assessed in prior trials to see if patients after liver resection would go on these drugs and see if there was a improvement in reduction of disease recurrence, and nothing was able to show that until this trial came out. So in summary, I kind of wanted to highlight a few different things, but I think the most important thing to take away from the treatment of HCC and the latest advancements is that HCC is really a cancer that requires multidisciplinary care. It's not just one physician, it's a multitude of doctors in teams deciding in multiple steps of a patient's journey what's the best option for that patient to treat that HCC. There's been a lot of recent and big advancements in HCC, but we still have a long ways to go. What a lot of the trials have recently shown is incremental improvements, but there's a lot more studies in the future and that are upcoming in the horizon. And it really highlights that there's a lot of potential for systemic and immunotherapy combination with other forms of resection or transplant or ablation to really improve outcomes. And it's going to be very exciting in the future. And I really want to thank everyone for listening.